This is the June Ethics for Lunch, a small but intimate crowd to review the past year of our sessions, which are sponsored both by the Ethics Committee here at the hospital and by the Berman Institute of Bioethics. I'm Mark Hughes, one of the co-chairs. Cindy Rushton's over there, our other co-chair. And we have a panel today to react to the presentation today. So, Zach, why don't you start?
I'm Zach Berger in General Internal Medicine and core faculty at the Berman Institute and on the Ethics Consultation Service.
Excuse me. Hi, everyone.
I'm not sure it's on. But...
Not on?
There we go.
Now it's on? Okay. Hi, everyone. My name is Amelia Simmons. I'm a nurse on Minor 9, and I'm on the ethics team.
And I'm Allison Turnbull. I'm an epidemiologist who does research in critical care, and I'm on the ethics committee.
Okay, great. So, as I said, this is going to be a review of the past year. It's going to be audience interaction, and I was struggling with technology, but I think I've overcome it. Hopefully you brought your mobile phones with you, your smartphones, so that you can participate because we're going to have a series of mostly multiple choice on true-false questions for you as an audience to react to, and then some of them may invite commentary. So we want your input, want your reactions to the cases. What we're going to try to cover are these things based on the topics that we did, the 9 sessions over the past year. These were some of the things we mainly addressed. Informed consent, decision-making capacity, thinking about ways to show respect for patients and families, especially for members of the community that might historically be disadvantaged or vulnerable. Discuss how to care for patients who refuse treatments or disagree with what the care team is telling them. And then at the end, we're going to hopefully invite your input about sessions we should have for next year. So we'll start again in September, and we'd like your input about things that are of interest to you to hear about. So for the 2019-2020 academic year. How many, show of hands, rather than we'll use the old technology of showing hands, people are familiar with Poll Everywhere? Okay, half of you. So this is just a way to walk you through it. I guess American Idol is still around. Any of these shows where you might, online vote or use your smartphone to vote. So you send a text message, or you can go to a URL and post your answer to particular questions or surveys. So for us, if you've got it, you send a message to 22333, okay? And what you put in the text message is JHH Ethics 553. And you should get a response saying, welcome to the Ethics Committee survey, something like that. Just try to get you to that place. Or you can go to pollev.com/JHHethics553. So either internet browser or directly via text message. And if you do actually get a reply message that you're in the survey, just raise your hand just so I see. Okay? Some people are still working on it.
Yes.
Okay. Good. Okay. All right. Getting there. All right. All right. It looks like we've got 3/4, so those who can continue to work on it. We've got opportunity for 700 responses. We don't have that many in the group here, but we'll try to get everybody's input about these questions. All right. So here's the first one. Quick poll. Here it is. So I've already mentioned how to get there. And I've already answered this question, just to make sure it was working, so this will change as you answer. Have you been to Ethics for Lunch before? Let's just see if we get responses triggering.
Are we entering A or yes?
A is yes, B is no. So enter the letter. In all of these cases, it's going to be the letter that you see inside the graph. And it doesn't tell me how many responses we're getting, but I'm going to give a reasonable period of time just to see. So the majority of you have been here before, so welcome back. For the 14%, welcome to your first Ethics for Lunch. All right. Now, this is a very complicated one, but just to get a sense of who is in the audience, probably too many categories, but A, nurse, B, physician, C, nurse practitioner or physician assistant, D, social worker, E, chaplain, F, physical therapist, technologist, G, researcher, H, community member, I, student, J, other. Great, this is actually working. Fair number of people identifying as researchers or other. And then we've got some social workers in the group. All right, so you know who's in the audience. All right. Now, here's the first topic, the intersection of decision-making capacity and mental illness. Oliver Wellcrom, 50-year-old man with congestive heart failure, diabetes, major depression. After stabilizing an exacerbation of heart failure on the medicine service, he is transferred voluntarily to psychiatry for treatment of depression and suicidal intent. He states that if he were given the opportunity, he would overdose on his heart and diabetes medicines in order to end his life. Consequently, he is directly observed taking his medications on the psychiatry service. For his heart failure and diabetes, he needs to be on a restricted diet, which he does not like. Some days, he skips meals if he does not like the food. One day, his blood glucose level is found to be very low, and there is concern that he could go into hypoglycemic coma. Although currently, he is alert and interactive. He refuses to eat or drink what the psychiatry staff offer him. He also refuses an infusion of D50, dextrose, sugar, or an injection of glucagon, all of which would raise his blood sugar level. He knows that he could die if he slips into a coma from the hypoglycemia. He reminds the psychiatry team that he has an advance directive stating he does not want artificial nutrition or hydration if he were comatose. Okay, so here's the question for you all. How should the psychiatry team respond? A, accept his refusal because he has decision-making capacity, i.e. he understands the consequences of his refusal. B, wait for him to slip into a coma and then treat him counter to his wishes. C, leave sugary foods and drink in his room and let him decide when or if he will consume them. Or D, tell him he does not have capacity to refuse the medicine or dextrose and restrain him in order to administer them. Or E, other. And the caveat with other is if you say other, you have to tell us what your other choice is, what your option alternative is. All right, so again, I don't know what percentage of people, when it's 12%, how many that represents, presumably more than one. But anybody, looks like we're heading towards C. Or A is the second one, but anybody want to mention what their E option is? For those that answered E? Yes?
I think we need just a little bit more work about what he is willing to eat in ways that, discuss things, preferences, or help him be in part of the decision-making process.
Okay, so a little more conversation, negotiation,
Right.
trying to get to a common goal with him of, can we find a food that he will eat?
Right.
Okay, so more discussion is your advocating. Any other thoughts? Yes?
Maybe also engage the family and see if they can help with the decision making.
Okay, so does he have others in his life, family members, friends that could be advocates for him? Is it possible to call them on the phone or bring them in? and say he's refusing food and drink, he's got a very low sugar level, we're very concerned about him, could you talk to him? Okay? Other thoughts? Our panel, any options here? And what do you think about people just saying, well, leave the food in there and he'll eat it when he wants to, if he wants to?
So I guess my first question is, what if we call the family and they say leave him alone? I think we're making an assumption that the family will want him to be fed.
I think it's even though it says in the vignette that we already know that he understands, I feel like I answered other because, as was said by other people, the more you talk to people in these situations, the more you understand about them, and understanding is a very complicated thing, especially for somebody who's thinking of suicide and has been in the hospital for some time, and food is a very fraught thing in the hospital, right? When you get to eat, when people are telling you to eat, right? But I have to say, I like the option of leaving candy around his room, sort of like a Garden of Eden motif, right? Maybe you should tell him don't eat the Hershey's, or this reverse psychology. But I think more conversation is generally a good idea in my mind.
Really want to say?
I'm pessimistic in saying that I think D is what would happen in the clinical setting, because if he says that he is actively suicidal and he has a reasonable means to carry out his plan, this is us letting him fulfill his suicidal plan. If his means for suicide was to, jump off of, go skydiving and not pull the parachute cord, that's not a reasonable plan. So I would, as the nurse, I would definitely want to ask him, is he actively suicidal, and is this his intended plan to end his life, in which case you can't be complicit with that as a healthcare provider. So you would have to, again, more conversation, and does he just not like that lunch? Can you get him something else? Is there a really easy solution to this? Does he want a real Coke as opposed to a Diet Coke? There are ways that maybe it doesn't have to be a bigger deal, but you definitely have to address, first of all, is he actively suicidal with this as his means?
Okay, any other thoughts? Yes?
I'd be curious to know the amount of conversation that happened before he was admitted to psychiatry. I mean, that might have been the place to address a lot of these issues, because can we assume that he accepted a treatment for his depression because he accepted admission, or was he offered an option not to go to psychiatry? And so I think the point for discussion might have been before the transfer to the other unit.
I would also say that underlying all of this is a question, which is, does this patient have capacity?
Yeah, so I think that the voluntarily going to the psychiatry service implies that there was a conversation that he wants treatment for his depression. He'd like to get over his suicidal ideation. So I think that was part of the plan in him going there. We'll manage your depression so you don't feel as suicidal. And the question is this not treating the hypoglycemia suicidal intent? Does he really end his life? In which case we might say maybe he doesn't have capacity because his judgment is impaired by his depression. People are changing their answers as we talk.
Not to belabor the point, but was he fully informed about what transfer to the psych unit meant? And if you refuse to eat, that would compromise our ability to manage it, and so on and so forth.
Okay, so part of the discussion, both before he gets there as well as now when he's got a low sugar, can you have more discussion with this? All right. Now, he has major depression with suicidal ideation. The says that he has an advance directive saying he doesn't want artificial nutrition. Can he refuse other life-sustaining therapy like cardiopulmonary resuscitation, CPR, mechanical ventilation? A yes, B no, or true false in this case. So we're saying, everybody was saying yes, he could refuse. Oh, there was some 17% saying no.
Third option.
Sorry. Do you want
Maybe.
he cannot refuse as true, or he can refuse as true?
I have it as a double negative there. So, it is saying that he cannot refuse. Is that a true statement or not? Now people are reading it a little bit. Now flip the A and B. People are 50-50 close to it. Well, now we're shrinking. Fortunately, I allowed for changing your answer. All right, but looks like 2/3 would say this is a false statement, that he should be able to make, again, if he has capacity, be able to make decisions about life-sustaining treatment. Is that our conclusion?
That's what's baked into the question right here. That you have to read the question either understanding, or either agreeing or not agreeing that he has capacity given the suicidal ideation, right? So that's implicit. Take the question one way or the other, right? Depending whether you think he has capacity in the situation.
Not an automatic just because he has depression that he doesn't have capacity. It would have to be assessed for each of those other decisions. Okay. All right. Our next topic for the year in October was care of transgender patients. One of the take-home points from that is for patients or family or visitors to the hospital in a world where they may feel unwelcome, just small gestures can make them feel more welcome and accepted. So one suggestion is the use of pronouns and making acknowledgement of how people may use different pronouns to have themselves addressed. And what pronouns do you use to ask the person? So here's the question. Is this a true or false statement? All healthcare personnel should be trained in gender identity and gender expression. A true, a false. Give me enough time to answer that. Okay, it looks like everyone's in agreement. All right, now, two soon. If a healthcare provider mistakenly uses the wrong pronoun for a transgender person, what should they do? A, apologize profusely and announce to the whole team how the person should be referred to in order to show respect. B, apologize in a nice way and move on with the rest of the encounter. C, continue to use the pronoun that matches the person's birth gender. D, continue to use the pronoun that best matches the person's appearance in the eyes of the healthcare provider. E, other. A few A's, less A's. We've got at least one E. Can I hear from the E option?
I think apology is, in a nice way, is fine, but I would ask the person how they wanted to be referred to. Just verify that, in fact, what their appearance may or may not suggest.
Okay, so in addition to the apology, there might be just, let me verify what pronoun you wish to use,
Right.
you wish us to use. Okay. Zach, you take care of some transgender patients. Any thoughts about this one?
I can say personally, I've made an error, this error before referring to people by the incorrect pronoun, and I apologize in a nice way, and then I say something about how, this is not something that comes naturally to me, and I am learning, and I appreciate your patience. That seems generally to work. Maybe it's in between profuse and not profuse as far as an apology goes, but I feel like it's helpful.
I just want to speak very briefly to A and why that's even a question. So there is thinking that when you kind of apologize a lot and say a lot and express how upset you know and how embarrassed you are and so forth, in a sense, part of what you're asking that person to do is a certain amount of emotional labor to assure you that everything's okay, right? So you're kind of asking them to make you feel better. And there are people who say, like, just don't do that. Don't ask me to do that for you. Just say, sorry, ask, and move on. Because I'm here for my health, not to help you think through this big issue and feel good.
I think that was the conclusion of the panel.
One other thought, you're only suggesting that there might be two genders, pronouns of reference, and assuming one or the other without recognizing that there might be a choice by the individual of a third pronoun or a third way to refer to them.
Right, or no pronoun.
Or no,
Yeah.
right.
So again, asking the person. All right, so now it's the parents of a transgender adolescent. They refuse or just continually forget to use the pronoun by which the adolescent wishes to be called. So what should the healthcare provider do if this is happening in front of them? A, ignore it as a family issue that they should not get in the middle of. B, remind the parents of the pronoun by which the adolescent wishes to be called. C, state that everyone should be after the same goal of achieving the adolescent's best interest. D, ask the parents to step out of the room so the adolescent can be cared for in a confidential manner. Or E, something else. And they need not be mutually exclusive. It might be what your first step would be. So a good majority of people were going more for saying we're after this adolescent's best interest as the first response. For our E choices, anybody want to comment?
We'll give others a chance. I will.
Okay, of course. Panel, any reactions?
And I would put E, and I think I would say it somewhat differently than C. I would make a general remark, I guess preferably not directed to the parents, but to, maybe there's someone else in the room too, but saying something like, that this person must be referred to this way, so I think we should do that. And then, I guess it's tricky if the parents are the only ones, preferably not directed to the parents, is to lower the tension level. That's why I think C is not quite, to me, the sufficient thing to say. I think we need to be more specific about what's going on.
So you might go towards a B, in that case, the pronoun by which.
Yeah, right. Ideally, I could frame it in a way that it's not direct, like not turning to the parents and saying, actually, but saying something like, here we all are, I think this person has this preferred pronoun, we should use that, I'm going to use that going forward, just FYI. Maybe a slightly less tense of a version.
Yes.
So I don't know exactly how you do it, but I think you could ask the patient, would they prefer that their parents left the room while you're treating them? Just because they have this particular conflict doesn't necessarily mean a child wouldn't want a parent present for their treatment. So I don't think you can unilaterally say, oh, if you guys don't respect this, out you go. Because a medical visit could be a time of duress for a kid where even everything else aside, they want their mom with them. So I think if you could find a tactful way to ask the patient what they would prefer, if you would prefer your parents to leave, that is your right, and I can make that happen. And then we can deal with this privately, or, otherwise ignore it or handle it not tactfully.
Okay, and in adolescent medicine, that may be the norm in any event of having some opportunity to meet with the patient, the adolescent by themselves, with or without the parent, and then the child gets to decide, I want my parents in for this part of the visit, and so on. Okay. All right. The next topic, I'll ask this one first, and then I'll go back to my longer question. Next topic in November was whether a woman that has HIV should be allowed to breastfeed. So here A, agree, B, disagree, C, it depends. And if you choose it depends, then you got to give us what does it depend on. Yes.
So in terms of my choice, as it depends, I think that people who want to breastfeed do it for certain reasons. I think we're obligated to understand their reasons and to help them to understand what we know to be their risks. And I think, and also for follow-up and how to do it more safely as opposed to not. So I don't think that you could say, great, go ahead, without having some sort of an obligation to help them understand what's in everyone's best interest.
I think their actual status, their viral load status plays a factor. How active are they would increase the risks of transmissions to the infant. So I think that plays a big factor in this. I don't think it's just like
Not solely being HIV positive, but if they have a viral load that's detectable, how...
Or if the baby gets sick, they need to check the baby. The baby's going to need to be on medications that can cause liver damage. They need to be made aware. It's not just doing it
Okay, so part of the informed consent are the risks and the benefits, with some attention to what the panel in November talked about is harm reduction
Exactly.
Process. There are benefits to breastfeeding, but the woman needs to be aware of the potential risks as well. Okay. Now, what about the hospital? Is it ethically permissible for a hospital to establish a policy that it will not permit a postpartum woman to breastfeed while she and or her newborn are inpatients if the woman has a detectable HIV viral load? So it's not a woman that's HIV positive where there's no virus. She has a detectable HIV viral load. can the hospital say, well, you cannot breastfeed if you're on our, on our in-service? Pretty definitive, no, they cannot establish a policy. Comments about this one, or panel want to react?
Well, I just feel like we can't limit a mother on her actions on anything that would say, by virtue of motherhood, you have decreased rights. We can't say smoking's bad for you, especially while breastfeeding or using illicit substances, but we can't make a policy that says you can't be our patient if you do those things. So I don't think by virtue of being a mother, you have just decreased rights, even though there are risks to the infant, but I think going down those pathways can be harmful.
I would say it's helpful to think about this question in the context of other questions. So when do we restrict parental rights? How much danger does a woman have to put her child in before we call child protective services? We permit parents to make decisions not to vaccinate their kids. We permit parents to make decisions to bring kids back into homes where we think domestic violence has happened. I'm not coming down hard one way or the other, but I think it is important to think about this as just another example of where we decide how much risk a parent is allowed to put their child at.
I would just add to that point that this is not merely a simple question of should we do or not do. To take action, one would consider taking protective custody of the infant, which engages a whole new social and psychological realm of things that are going to be injected into the situation. So it's not really, well, should we make a policy or not? It's the policy to do so would involve engaging state authorities and a whole bunch of other things. And what's the threshold for doing that?
Creating other harms to the mother and to the child.
So looking at downstream consequences of instituting policy like this. What if a nurse on the floor says, well, I just cannot take care of this woman if I know that, or let's say it's a neonatal nurse, and it's, I'm concerned about this infant who is my patient. I do not want them exposed to this potential risk. What's the recourse there if it's not a hospital policy?
I think any provider has a certain right of conscience that is constrained by professional and social obligations to care for patients. So I think anybody is allowed, and there should be policies and practices that make that allowability real, right? To be able to not violate your conscience. On the other hand, you can abandon patient care. So depending on the particular situation, I would say someone should be allowed to say that if they find someone. Of course, there are values that should be universal in the hospital, and there are reasons for objections of conscience that we can't allow, I think. This would not be one of them. In general, I think that's the principle at play here.
I guess I would just say, I think this is a currently really thorny place in our society right now, because there are increasingly legal involvement in the question of when healthcare providers can refuse to participate in care based on religious preference. I would just say watch this space and be really aware of it, and think about whether, we've generally said it is fine if people have a conscientious objection as long as that conscientious objection is not used to justify racial or religious discrimination or gender discrimination or something like that. But it can be hard to decide if that's really what's going on, and increasingly the law is getting involved here. So I would say be very aware of this question going forward in the next few years.
And I would say, piggybacking on this question, the previous question on hospital policies, this particular question you asked was not about a hospital policy of conscientious objection, but I would say hospital policies can be blunt instruments, right? So especially when dealing with, for example, a healthcare provider that wishes not to provide care to a patient, whether broadly speaking you should or should not allow that. A lot goes into the details of the policy, and that might be too blunt an instrument to address that touchy question.
Okay.
Question, isn't it the case that the Joint Commission requires a hospital policy on conscientious objection?
Yeah, and we do have one on conscientious objection. Whether this the nurse refusing for concern about harm to infant counts as a conscientious objection, and whether it be invoked or other nurses could, oversee the care of the infant. Those things would have to be worked out.
Thanks.
All right, so here's an option. Even though it may be expensive, a hospital should provide, at no cost to the patient, banked human milk for all mothers who are HIV positive. And it's $5 an ounce. I don't know how many ounces in a day an infant consumes, but could get to be very, very expensive. Thousands of dollars per month. So a lot of people thought, yes, hospitals should provide it. We're changing. So split decision here. All right, I'm gonna just see if there are any reactions to this one. So I think it's economically may not be feasible for all women. It may be something to offer as an option, but then is it really going to be affordable for the institution to do it? All right. Last one, I think, on HIV women. HIV mother whose family does not know her HIV status agrees not to breastfeed her infant, but asks the healthcare team to give her medication to prevent milk production, and to tell her family that the reason she is formula feeding is because she does not make enough milk. So how should the nurse respond in the nursery when the grandparents of the infant ask in the presence of the mother why she is not breastfeeding? A, state matter-of-factly that the mother does not make enough breast milk. B, defer to the mother to answer their question. C, state the nurse state cannot discuss confidential matters with grandparents. D, state that it's because the mother is HIV positive and is nothing to be ashamed of. Or E, other. Sounds like people are going with B. Few C's. And what's our E choice?
Well, that was me again, and I thought this is an anticipatable issue at the time of the mother's statement to the healthcare provider about what her desire is, and could be addressed, the question could be addressed, how do you want me to deal with this when your family may ask, or somebody may ask about this, and I will not lie for you. So, given the context, ask her, the patient, to offer some options about how to, or offer the patient some options, but
Okay,
not to
so
lie
some
to the
anticipatory
family.
guidance beforehand. Yes.
A and D are both privacy violations, so I don't think she should do either of those, right? I mean, any information about her medical condition is not the place for the nurse to be discussing with anyone besides the patient and like delegated representatives. So I don't think, I mean, nobody chose them, but I don't think they're on the table anyway. But it speaks a little bit to his question of how I won't lie. Well, you shouldn't lie. You shouldn't tell the truth. You shouldn't give any answer. It's not her answer to give to other people while the person's right there, or while she's not.
I guess the question would be, does it put more pressure on the woman to justify why she's not breastfeeding?
I would also just say that kind of practically speaking, at least in the ICU where I am, we are very frequently talking to family members, especially for unconscious patients, but sometimes even for conscious patients. And we do not ask for your ID when you come to visit. So the reality is we are talking to families fairly regularly, and if you suddenly claim up and say, oh, I can't talk about that, yeah, it raises red flags for a smart family who's been told stuff for days. Why suddenly you got nothing to say?
And I think actually in the HIPAA training module, if I remember correctly, there's a specific case of if people are in the room with the patient, right, and they're clearly there on the patient's, about what, the patient wants them there, right, you can talk about things with them there, if that seems to be an implied relationship with the patient.
I guess there could be in the moment asking the woman in the presence of the grandparents, we don't know if the in-laws or her parents, but is it okay if I answer that question?
I'd just like to bring forward a ethics consult we requested several years ago in the full-term nursery, where multiple times mothers do not want to disclose their status to the fathers of the baby. However, the father also has a right to the infant's exposure or potential, as well as his own health. So, I mean, it was just a long-term process, but we do cover the AZT during labor so that the question doesn't come up. and we try to help the mothers to disclose, but ultimately we don't basically spill the beans either. So, and again, the mothers often will say the baby's receiving vitamins. What we don't want to have happen is that the mother doesn't give the baby the AZT in order to hide the diagnosis. So whatever we have to do, and then we do have a very supportive HIV obstetrical team that follows a peer group, but we don't have the right answer for every patient, but we do try to anticipate how best to handle it beforehand.
Okay. All right, the next topic was distrust around neurologic death. So December is always our spiritual care session. So this case, 18-year-old man sustains a gunshot wound to the head, has massive brain injuries requiring decompressive craniectomy by neurosurgery. Over the ensuing days, the patient remains comatose. An MRI shows profound brain injury. He is ventilator dependent and does not breathe on his own over the ventilator settings. Neurologists think that his prognosis is grim. Based on the initial neurologic exam findings, the neurologists suspect that the patient does meet criteria for death by neurologic criteria, i.e. brain death. They approach the family about doing a formal brain death exam, but the family refuses the testing. Here are your options. So how should the neurology team respond? A, accept the family's refusal and continue life-sustaining therapy. B, accept the family's refusal, but unbeknownst to them, proceed with the first brain death exam. C, tell the family that they cannot refuse this particular diagnostic exam. D, order additional tests like cerebral blood flow to see if they are consistent with brain death. Or E, something else. Split here. Now people are going more towards ancillary tests. And we've got an E choice. What's our E choice?
I think it was me.
Okay.
I mean, you'd have to ask them why, right? Like, what is it about the test, right? Tell me what you think about your family member's situation, prognosis, and why you don't want us to do the test.
Okay, and this is specifically framed in the distrust by the team of how do you bridge that gap to build trust, finding out their reasons for why they might be making this refusal.
Question? Are we obliged to ask the family for permission to perform a brain death exam in this situation, or would it be accepted as acceptable medical practice included under the general consent or whatever for treating such a patient?
I think the law would say that for the general consent to be a hospitalized patient, you have to determine if they are a patient and whether they are living or dead. So I think our institutional policy would say if you suspect that they are dead, by neurologic criteria in this case, you need to do the diagnostic test to confirm that.
And not require consent of the
And not require consent by the family.
Thank you.
Then I think asking the family in the first place is, that's wrong. So if we're gonna do the test anyway, we should tell them, hey, just so you know, we're doing this test to check for brain death. Here's what it entails, but you shouldn't ask them, can we do it, and then not accept their no.
If you're asking consent, that implies that there is a yes or a no to the answer. So these are the reasons that might be given by the family. Would you consider them persuasive in not pursuing brain death exam? We've already established that maybe you should if you think that there is death. But the religious beliefs do not accept the concept of brain death, only cardiopulmonary death. B, they believe in miracles and still hope for the young man to wake up from his coma. C, they are worried that the brain death exam is too risky, especially the apnea test. D, they do not trust the healthcare teams telling the truth about the patient's condition. E, all of the above, or F, none of the above, and something else. And the reason for none of the above, for the 100%, is because it's a diagnostic test that we have to do. That's the conclusion. Okay, so then we will move on. Oh, there's the name. Does anybody want to speak to the religious beliefs, either believing in a miracle or saying we don't accept the concept of brain death? And there are some states where that is the case. You can have a religious exception to diagnosis of death by neurologic criteria.
Said on one of my units, the patient had the test done, the brain death test, and the family refused to take the patient off the ventilator. And from that point on, they went to court and got a document stating that to hold off, we removed the ventilator, and they removed the patient from JH.
So there might be recourses for the family if they really are disagreeing. Again, Maryland doesn't have that religious exception, but there might be other avenues for the family to pursue. Again, some of this is going to come down to the discussion that the team has with the family about what's actually going on. All right. Now, possibility of organ donation. So also state law that you have to offer the option of donating the organs if a person has been determined to be dead by neurologic criteria. Hard to read for the choices. When should that discussion happen? Offering organ donation provides a positive in the midst of bad news. So that's why it should be done at the same time of telling that the person is dead. B, because it streamlines the process for the family so they do not have to hear a series of meetings from different people. C, which people have already chosen. The discussion of organ donation should occur at a later time after the family has had a chance to grieve. D, because the option of organ donation should have already been brought up with the family when it is suspected that the patient might be brain dead. It sounds like people are going with C even before I've answered asked the question. So what we talk about in our hospital policy is decoupling. So there should be separate discussions of person is dead, we're sorry for your loss, and then we're going to have a series of meetings, let you have some time to spend with your loved one. But some other folks will come back later to talk about some other things. And then that's where the organ procurement representative organ donation would be raised with the family. Okay. Now, the other thing that the December session pointed out is we have a family advocate. Anytime a person comes in with a Glasgow Coma Scale score of 3, so severe neurologic injury and comatose, they are contacted that the person might progress to brain death. So whom is that family advocate ultimately responsible? A, the patient, B, the family, C, the institution, D, the organ procurement organization, or E, others. It sounds like people are going with the family. Some would say the patient. Any comments on this one, or panel want to react to this?
I guess I would just say, if it's the family, then the name of the person's job is really misleading.
If it were not the family.
Yeah,
The fact that they are family advocate.
If their job name is family advocate, if they are beholden to someone else, we need to give them a different job.
Okay, any comments on this one? So they have to navigate this space between advocating for the family, who might be distrustful and perhaps disagreeing with what the healthcare team is telling them, but also being a bridge to the healthcare team to help explain concepts and clarify what the physicians, nurses are trying to convey to the family. So it can be a challenging place to be. And they are employees of the institution. So our 6% that answered that is in the mix, but they ultimately are responsible to the family. Okay, families in spiritual distress in light of their loved one facing a devastating life-limiting illness. In hearing the patient's story, the chaplain ministering to the patient and family hears many similarities to their own life history. Is it okay for the chaplain to share details of his or her life to make a connection with the family? A, yes, B, no, C, other. We've got some chaplains in our audience. We had a few for C. Anybody want to say what the other choices would be? No?
I would say there's a way to share detail or your life story without sharing details necessarily to make that connection, where you're not making your life story, the big to-do. It's still about the patient. And so, you can kind of make that connection by sharing some, similarities, but not really overriding with, bleeding, we call it bleeding over the patient.
Okay. So making the connection, but still focus on the patient and or family, not the chaplain, the minister. All right. The next topic. In January, patients with substance use disorder needing cardiac surgery. So Ms. A is undergoing treatment for recurrent endocarditis, is getting IV antibiotics. She has a history of intravenous drug use, IVDU, and previous mitral valve endocarditis, for which she received a mitral valve replacement 2 years ago. She admits to a relapse with her injection drug use, says that she has no interest in rehabilitation and treatment for her addiction. She will continue to use drugs. She has been referred to cardiac surgery for replacement of this prosthetic mitral valve. So in addition to the antibiotics, it's thought that the valve needs to be replaced. Should the cardiac surgeon consider mitral valve surgery? And here I'm only limiting you to yes or no. Yes, A, B, no. When do I stop? Go back. All right, so the majority would say there's still, yes, the surgeon should consider it. Comments about this one? Yes?
I think it could be considered depending on the patient's willingness to enter into a treatment program as well. But if she, even once the conversation occurred this time around still, says she wants to continue using them, at that time I would say the decision should be made not to go further.
Right, I'm sort of on the same track, right? I'm not saying it should necessarily be done, but I don't think it should be rejected completely out of hand. I think I won't even consider treating you because of this. I do think you should always consider treating somebody. There may or may not be a mitigating conversation that affects the ultimate decision, but to sort of just say I won't even consider it to me is a little cold.
I would, and that goes to the larger conversation of when we do and when we don't blame patients, right? I think many healthcare providers, because of our system, are conditioned to blame patients. And in this particular setting, one thing that would come to my mind personally is that it's not the intravenous drug use that increases the risk of endocarditis, right? It's a lack of safe consumption spaces who use recreational substances, right? So understanding how we stigmatize various uses of some substances and don't stigmatize other substances should affect how we understand whether or not we should offer appropriate care to this patient.
So safe needle houses or needle exchange programs or other options might be available if she wanted to continue with her substance use, and might be a separate discussion.
In another
Part-
state, right?
And another state, in another country.
Right.
Separate from whether or not she should be a candidate for surgery. Okay. All right. Now, this is a agree or disagree statement. I've given you a few options. The cardiac surgery team can stipulate that they will only consider, and this is part of what we just said, only consider repeat valve surgery for patients who agree to participate in a drug recovery program. A, agree for as many valve surgeries as are technically feasible in the future. B, agree but for only one repeat surgery. After that, the patient should not be offered any more. C, disagree. It is coercive for the surgery team to put conditions on the surgery decision. D, disagree. The patient should be free to decide whether to continue drug use irrespective of the decision about surgery. Or E, something else. It looks like people are going with the autonomy of this patient should decide whether or not they have drug use or not, and whether there's surgery or not. Getting a few more B's and C's here. Any comments on this one? Panel reaction?
This is a topic that I struggle with a lot, and I think what I'd want to think about is the overall long-term health of that patient and what poses the greatest risk to that patient and where are we putting our resources as a hospital. Because I think most of our IV drug users have underlying psychiatric conditions, and we can spend a lot of money replacing valves. but are we fixing their ultimate major health problem, which is psychiatry? So from a larger perspective, as a hospital, I would want us to focus on more services towards psych support, outpatient services, and addiction services, rather than just replacing valves indefinitely, because I don't think we're actually doing any justice to that patient by not giving them options to fix their underlying condition.
I would point out that we're actually very comfortable saying no when there is a clear scarce resource, right? When we're talking about organs. So if you're not a good candidate and we have a limited number of organs, we tell you no pretty quickly. This is a situation where valves aren't limited. And so it's very easy to say, why not? This is not a scarce resource, without recognizing that money and beds and time are also scarce resources. It's not as easy to see what's left and how it will impact other patients. It's very easy to say, if I put this liver in this patient won't get it. It's harder to say what won't happen if money and time is spent on this patient's valve replacement.
I think that's a great comparison between valve replacement and transplant, right? Because transplant doctors and all sorts of doctors make decisions all the time about which patients are worthy or not worthy, right? We don't put it in that language. These sorts of decisions are often very inconsistently and heterogeneously made from doctor to doctor, depending on what sort of patient it is.
All right, the next topic was genetic testing. So in particular, when it's enrolling families in testing, and there might be research or clinical use. So a family, mother, father, 12-year-old daughter, agrees to genetic testing when their newborn son is born with congenital abnormalities. The parents indicate they only want to know the results for all 4 of them, the daughter and son included, that bear on what the genetic diagnosis is for their son. I.e., if you find out other things in the genetic testing, we do not want to receive those results for other serious medical conditions, just what pertains to our son. The testing does not identify a cause for the son's condition, but it does identify a mutation that could increase the daughter's risk of developing cancer later in life. Okay, so you've learned some results don't pertain to the son's particular condition. Should the daughter be told of the genetic test results, even though her parents did not want this information when they signed the informed consent? A, yes, right now you should give her the information at age 12. B, yes, you should give it to her, but wait until she's 18 and an adult. C, no, this is the parent's prerogative not to receive this additional information. D, no, she should not be told, but the parent should be told irrespective of their earlier decision. Or E, something else. And we're going with a lot of E's here. Thoughts about other options?
I think kind of like a combination method, like maybe contact her at 18 and be like, do you want to hear the rest of your results?
So waiting the 6 years.
Yeah.
And
But not
giving her
just
the
outright
option at
telling
that
her,
time.
but giving her an option.
Okay. We had results back when you got testing for your brother. You can learn them or not at this time.
So when they gave her the test, so she's 12, did they have a discussion with her about her consent to genetic testing, or was it solely based on her parents' consent?
So there might be a need for assent by a minor. Do they agree to the testing if they can't give full informed consent themselves, but the actual consent was by the parents. So maybe there was some discussion with her, but it still might be the parents saying, well, we don't care what you think, daughter, you're not going to get the results.
Yeah, see, to me, I think that matters to me, because I think a 12-year-old, while not old enough to maybe consent on their own to a lot of things, like most 12-year-olds probably would be able to form an opinion about if they want that information, and I want to know what their opinion was at the time when their parents said they didn't want it, and that's important to me. I don't think the parents should be told if we ask them if they want to know and they said no, but I think the daughter's opinion and viewpoint on that matters too, and we don't really have it in the case as it's given.
Okay. Is there a comment?
I think you could have some further discussion with the parents, maybe. Maybe even without disclosing, but I don't know, some kind of further discussion that kind of indicates that, hey, maybe we saw something you might want to know something about, to see if maybe they change their mind.
So just some sort of feeler of, we might have seen something, just want to know if you really.
We saw something, we might have seen something.
Right, but this came up when, I remember this original presentation, this came up where if you're informing them ahead of time and they're giving informed consent, you can't then go back and second guess their decision because you don't feel comfortable with the results of that. It goes at the question someone asked earlier, why are you asking me what I want to do if in the end you're going to do what you want to do anyway? So I think if you've given somebody, someone's given actual informed consent, I don't think you have the right to then go back to them and say, I know that you said this, but let me just tell you what I think you should do anyway. Just as a entity, I don't like how that feels to me.
So I agree with that sentiment in general. Two things I would point out. One is that we routinely ask people to make medical decisions and then go back to them the next day and say, any chance you've reconsidered while they're inpatients, right? And that's really problematic to me, but we do it all the time, especially when we get new test results, right? So now we've learned a little more. You sure you don't want to rethink what you said yesterday? The other thing is, I really like your idea about not disclosing anything, and then when the daughter is 18, letting her know genetic tests happened when you were 12. Are you interested in the results? My fear here, I mean, I think that's kind of ideal, but a lot of times I worry that these studies or clinics won't last that long. That this information may not be around, or her contact information may not exist when she's 18. So that worries me.
Care everywhere will find her.
Next.
Is it? Yes.
Whose responsibility is it to know 5 years later or whatever that there should be a follow-up?
That would have to be part of the process for if it's a research team or the clinical geneticists or genetic counselors. Do they have some sort of mechanism to trigger, okay, it's 6 years later, we need to contact this person. All right. Now, what about other family members? So if they could also have this predisposition to cancer risk, should the other family members be told? The parents, and they've decided about them and their kids, but what about aunts, uncles, cousins? Pretty definitive no. Okay, we'll move on. Oh, there's one. What's our C choice? All right, move on. All right, the next one, informed refusal. So patients who change their minds. Patient arrives in the preoperative holding area on the day of a planned surgery for which they met with the surgeon 2 weeks earlier at an outpatient visit. The surgery intern meets with the patient to obtain their signature on the informed consent form. In going through the potential risks of the surgery, the form includes the possibility of death on there as a risk. The patient refuses to sign and wants to go home. The attending surgeon is currently in the operating room on another case. So what should the intern do? A, convince the patient to sign by saying that, oh, those risks on the form, they're extremely unlikely, it just, they're there as a formality. B, declare the patient as lacking decision-making capacity, ask the spouse to sign the informed consent instead. C, cancel the surgery for that day, discharge the patient home with instructions to follow up with the surgeon at an outpatient visit. D, we've already been preempted, delay the surgery until the attending surgeon is done with the current case, knowing this will disrupt the operating room schedule and make the attending surgeon upset. Or E, something else. What's our E choice here?
I think you'd like to offer I'd like to offer the option to the patient of discussing it with the surgeon, presumably they had an idea of what was going on, maybe, when they spoke to the attending earlier, as often happens. But I can tell you what practically would happen. But this is my suggestion, getting more information from the patient about what they're thinking.
So finding out from the patient why they're concerned
Why they're
about,
concerned.
why have they changed their mind
See, they
relative
might
to,
wait to talk to the attending.
and then wait till the surgeon's out of the operating room. Okay. Yeah.
So I think it's important to consider not only that communication is happening, but not just the what, but the how. So you made a point of talking about the intern was presenting this information, and I'm sure that they did a lovely job, but perhaps they were not as seasoned or well-versed in explaining the risk for this particular surgery, which does exist, to this patient. And so having the same conversation with a different professional might yield a different result. So I think the importance of how something is communicated should be weighed.
Okay, and then perhaps the expert attending surgeon that presumably already had this conversation might be able to clarify things, or
And assuming there's a relationship between the patient and the surgeon, and they can come to an agreement.
and there are also the pitfalls of actually, getting a consent form signed when a person's in a pre-op area just before they're wheeled into the operating room. Logistically, that's not ideal. Hopefully that should have happened as the outpatient in that encounter when they did meet with the surgeon.
So two things to say here. One is that this is a great example of when you give the answer that isn't wanted, that makes the conversation continue. You get asked again. And if you're asked the same question enough times, can be very coercive, right? Like we think about that in police interviews. Eventually you learn the answer that is wanted, and you can give it to get out of the situation. So I do worry a lot about that. The other thing that I would say here is that I think that either C or D, something that delays surgery or cancels surgery is a good idea, because nothing more disrupts the operating room than delays and cancellations. Like, that is a terrible thing to have happen. It has a financial impact, and it creates a huge incentive for surgeons to do a really good job of their consent discussion early on so that this doesn't happen, right? Like, if you know that there is going to be a bad consequence and money lost and your day screwed up, if the answer changes, it creates this big incentive to do a really good job in your initial conversation.
Or an incentive to railroad.
Or to railroad,
Mhm.
yeah.
All right, and then our last topic of the year, I skipped ahead a little bit. So just refusing an aspect of recommended plan. Patient has been hospitalized for 3 months, has multiple medical problems, sometimes refuses daily care or medications for his chronic conditions, necessitates members of the healthcare team spending more time with him to negotiate the care plan to try to prevent him from having worse problems as a result of his refusal. Is it permissible for the team to set a limit on how much time they will spend with him to adjust the care plan in response to his refusals? A, yes, B, no, C, it depends. Okay, and there's a depends. Okay, what's our depends answer?
I think this goes a lot to the question of how, and what Allison was talking about before, how patients are allowed or not allowed to ask questions or disagree with things as they're inpatient, when they're inpatients, right? A lot of times the assumption is that people somehow suspend their decision-making, their assertive and question-asking capacity when they're inpatient, which is absolutely not the case. But it is the culture, and often in the hospital, that you're not supposed to ask what's being done or why, and you're not supposed to say no. So is this happening because people are unused to patients asking questions and saying no? Or is it that, that seems like what's going on in this case actually, or is there another way of understanding the story, and how much time is being spent really? All these, I think, really impact on how you answer the question.
I think we also need to be careful to think about the nurses or the providers that are spending this time, and whether they're spending this time because they are under the impression that it is their job to get to a yes. I think we've seen a bunch of instances in cases we've consulted on where what the team needed to hear was, if you offer in a respectful way that clearly conveys risks and benefits, and the patient says no, you won't be in trouble for them not sitting and negotiating with them for half an hour. And that takes a lot of burden off of nurses or residents who are like, oh, I'm allowed to take no. Amazing. And then they can kind of get on with their day. Because this does end up impacting other patients.
As a nurse, what I would say is when you have a patient who is very manipulative of your time. Manipulative in a strict sense of you say, hey, I'm gonna get you cleaned up now, and they say, oh, can you come back in 5 minutes? And they do that for 4 hours. Well, that 4 hours could have been given towards other patients who are accepting care. So limit setting is something that we definitely utilize, and offering a limited number of times and then moving on and documenting. It was offered, patient said no, that's within their right. We're not going to force people in some instances to do everything that we think is best for them. Some things we have to do, but I think it absolutely is fair for other patients to have good nursing care as well, because otherwise they just have the exasperated, overworked nurse who spent all day with one patient instead of caring to the other 4.
Okay, last question for the day is this one. So this is where you can type in a response, hopefully. Topics that would be of interest to you for next academic year. You can just state them out loud, or you can type it and see if it actually comes up on the screen. Okay, determining capacity. And hopefully by the fall we might have an actual hospital policy on assessment of decision-making capacity. Institutional ethics, which I presume is more organizational ethics. How does the administration, the hospital make decisions? Professional ethics and conflicts of interest. So again, for minors, children, what are their privacy needs, and when can parents access medical information about them, especially electronically? Culture and ethics. Any more details about what you're implying there? What culture? Euthanasia, assisted suicide. In days of opioid epidemic, how do we taper people off of opioids? Taking care of special patients or wealthy patients or VIP patients. Can undocumented patients get transplants? Okay, we'll keep typing away. Any final comments, suggestions, questions? All right, well, thank you all for coming today. Enjoy the rest of your day.